For the climax of today, that is for the clinical forum, may I call forth the speakers, rather the panelists on the dais. Dr. Vincent Chan, Dr. J. Balavenkat, Dr. Swaroop Markale, Dr. Satish Kulkarni, Dr. M.V. Kumar, and Dr. Sandeep Mutha. As the moderator, may I call upon Dr. Murli Chakravarti to please join us on the dais.
I don't think any one of the panelists need introduction. Yeah, we actually have circulated the topics that we are going to discuss this evening. One is the dural puncture. And these are the questions that the audience have given us. And at this rate, I think we might be here till about 7 o'clock. And Sandeep Diwan is still around here. He is not there, so he might stop me. Physically, he is capable of doing that also. He goes to the gym every day. But we'll try to cover topics. I thought that these are very important, relevant questions. Without much ado, we go to the first question. Balak, could you define dural puncture?
Actually, this session is in relation to PDPH.
Correct.
And you've seen the session in the morning on the failed spinal, and a puncture which happens, which produces a cerebrospinal fluid leak due to any cause is made. It's called a dural puncture. Could be surgical, could be anesthetic. But basically, normally if you see the CSF is divided into the one which is in the central nervous system and the another one in the spinal system. About 50%, as I said, about 30 to 80 ml is there in the circulating in the spinal subarachnoid space. And any rent that happens results in the flow of CSF outside, which is, we call it as a dural puncture.
I just wanted you to kind of emphasize that we may not even see the CSF leaking outside. We might have made a puncture, it might leak into the epidural space. So people may think that only when it starts dripping out of the epidural needle. It's not the case. That's how the definition is. Satish, could you just highlight the incidents in the literature and in what your clinical practice?
The incidence generally, it will vary depending upon the experience of the person who is doing the lumbar puncture. And the incidence quoted in the literature from anywhere between 0.5 to 1% to about 15 or 16%, depending upon which setup or what sort of, in a center where a lot of trainees are doing, say, epidurals, probably the incidence of post-dural puncture headache or post-dural puncture or something is much higher, and the headache would be higher. But in centers where experienced people or senior people operating, generally about 1% is the average incidence for unintentional post-dural puncture.
Sure. And Vincent, I wanted to ask you, do you find any clinical difference between lumbar, thoracic and cervical dural punctures?
Well, I cannot give you my personal experience because I don't have too many post-dural puncture headache incidents. I'm just joking. I think we see a lot more post-dural puncture headaches after lumbar epidurals because we did a lot of lumbar epidurals. The incidence that we see is higher due to the practice. Once I'm given this question, I search the literature, and there isn't much described looking at the differences. I think when we do cervical epidural, usually it's in the pain clinic situation. We are now doing a lot more thoracic epidural, but there is really no data to show one is going to be higher than the other. There was one paper looking at more than 1,000 thoracic epidurals. The incidence of posterior puncture was only about 1%, and there was no report of posterior puncture headache. From personal experience, I did have a few puncture at the thoracic level, and those patients seem to be okay.
Yeah,
they don't seem to have as commonly have pain as the lumbar
Yes,
puncture,
sir.
a puncture in the lumbar space. So I don't know exactly the reason why, whether the pressure in the thoracic level in the subarachnoid space is lower, less leakage. I do not know whether that is the reason.
Do
or
you
not.
think there is anything to do with the pressure in the CSF at that position and the position of the patient? Does it really matter, do you think? Suppose you do a lumbar dural tap in a patient in lateral position and a cervical tap in a patient sitting position, do you think that would matter?
I think most of the time we see it not immediately after, so it takes time for the leak to come on. So I would doubt that, because with time the patient will be, I assume, will be lying down. So I don't believe that would be the case. Now, whether the patient would right away tell us, I have headache, when the puncture happens sitting up versus lying, again, I assume that one is, up. Maybe the likelihood that happens right away is higher. But again, there is no real data.
Sure. Actually, our own experience is, in fact, we have published a large series of thoracic epidural in cardiac patients. We had the 3 dural taps. We never found any post-dural puncture headache. And my own personal experience is most PDPH are in pregnant women and mostly women and in lumbar. Anybody in the audience has any experience? Yes, Sandeep?
We found that most of this, what you told about pregnant women, young children or young patients, around 20 to 30 years, in summer season, they have more amount of headache, post-dural puncture headache, than the rest of them. If we do the same, in the same season when the summer is there, and the patient is old, 60, 70 years old, the chances of post-dural puncture headache or incidence is less.
Is it because they have
It is
seen a lot of other
more in the
headaches
young
in
people.
life?
More in the young people.
Yeah, because the young people have not seen headaches. And okay.
Murli,
yes.
I think in my experience, actually, what I feel is it's more common in the hospital staff or clinical or paramedical staff and doctors particularly, because there's more topic being discussed, more being chewed, and the more you get headache. That's what the actual problem is.
They can't hear you. He says it's mostly among doctors, anesthesiologists, young anesthesiologists, ladies and all that. Did you say that?
If you try to do epidural blood patch less than 24 hours, the chances of effective epidural blood patch are less. So you have to probably need to repeat it. But if you do more than 24 hours, the chances of getting epidural blood patch effective is more effective. And so probably 50% of the time, it is more going to be a therapeutic epidural blood patch. So more than 24 hours is most of the literatures and most of the research.
Does the panel agree to that?
Also, I think in why 24 hours and not do immediately is that probably more than 50% of the times you may not need, you may not get a bad headache for necessitating a blood patch.
Okay.
So if you want to do it, basically as such as he said, the results are not as good if you do within 24 hours. So they wait for 24 hours, and obviously later on, depending on the clinical situation, means what was the patient. As he said, if it's a young patient, if you are done for labor analgesia, where the incidence of headache is going to be much higher because of various factors, whether it's a dehydration or whether it's low fluid status. In those sort of cases, you will be a bit aggressive about managing both post-dural puncture headache and considering a blood patch at an earlier setting than compared to somebody of orthopedic patients will never get one. But suppose a 65-year-old somebody having a little mild headache, you might probably get away most of the times with conservative management.
Vincent, you have something to say?
If you have created a dural puncture in a young anesthesiologist and she complains of headache right away, would you do a patch right away then?
Best is to apply leave.
Huh?
Apply leave. Ask your colleague to take care of the lady. Yeah, I don't think... yes, Bala?
No, I think this would be purely based on the symptoms of the patient, and I'm not sure how many of you have seen symptoms. Majority of them, of course, they have severe nuchal pain on only sitting up, and it's posture related. But occasionally you come across patients who have excruciating discomfort even with a small 10 centimeter pillow, even when you raise it to that level. And the intent, and they also have associated with it, sometimes they have nausea, they're not able to eat. That's a very severe form of PDPH.
Sure.
So I think one of the important things probably we need to take into account before giving an epidural blood patch is also the degree of symptoms that is exhibited by the patient. In our institution, one of the highest groups which gives, again, it's the young patients, especially those who come for arthroscopies, and these are the group which we face this, and normally we try to maintain them conservatively for 3 days, and most of the times it gets cured by itself conservatively. But there are instances. This year we have to give 2 blood patch, but also it's very, very important when you decide to give a blood patch, it's very important that the whole thing has to be done with tremendous amount of asepsis.
Correct.
And it's very important to follow that, otherwise we are going to compound the problem of
No,
the
you should not have another dural tap during the blood patch. I think that's better to be done by a little more senior anesthesiologist with about 1,000 or 2,000 epidurals. Yes, Swarup?
Hello. What's that?
Somebody is sabotaging the Australian.
Oh my God, thanks. If you see the epidural blood patch effectiveness, then first time the incidence of actually effective epidural blood patch is almost 50%, and almost 40% of the times you have to repeat the epidural blood patch. And the chances of getting another dural puncture during the second time, it's equally almost around 30%. So it has to be, you have to consider
Actually, Sandeep has announced an award for somebody who was doing a blood patch and done another dural tap. Anybody here going to do the dural, blood patch and done another dural tap? No. Okay.
That will be a challenge.
Yeah. In the next hour, we would like to have a competition. How many who have done?
Murli, one more thing. In the labor analgesia textbook, basically, it's written that if you have a puncture, you pass the catheter and keep. And you wait for 24 hours and then remove the catheter, the chances of headache are less.
Actually,
if you don't pass it,
correct.
If you don't
That means
pass it,
you will
then-
reduce the size of the
it
effective
will reduce the
size.
size of those.
I would strongly suggest all of you to read the guidelines, NHS guidelines about what would you do when there is a dural tap in a pregnant woman for labor analgesia. It's very, very beautiful, and they suggest that you go ahead and give a spinal, and every top up 3 ml of 0.25% bupivacaine. Only you top up the patient. It's not a nurse that you have trained will top up. You keep, and as soon as the baby is born, everything is fine, remove the catheter. So anybody has a comment on that?
I think there's a meta-analysis which came up recently, which I showed that previously the perception was that you put in a catheter through the dural puncture and keep it for 24 hours, the incidence of post-dural puncture is less. But the meta-analysis has failed to show any difference between these two techniques, and probably you're just postponing the onset of the headache. Maybe the severity of the headache might be less. Only good thing about it is that you can actually give a good quality analgesia.
Sure.
Or anesthesia you can continue if you put through the catheter.
Sure.
We actually, even I do that. I do that in all our patients. If there's an accidental dural puncture once in a while, whatever, we put in a catheter inside and keep for 24 hours and then remove it. But a lot depends on what your setup and backup is, because keep an intrathecal catheter either on the ward or your critical or your HDU
It is dangerous.
not without risk.
Yeah.
So as long as you are pretty sure that somebody is not going to inject something thinking that it is an epidural catheter, that you have to be 100% sure.
No, nobody else will have access other than you. That's you have to
Yeah,
ensure.
but because most of the times what happens is our pain nurse would probably go and give top-ups, or
Yes.
there may be a number of people involved in the pain.
In fact, we have a blog in Bangalore called Force. It is a Fortis ongoing research and continuing education. We had a similar case scenario posted there, and in that case scenario, the report was that they gave a test dose before giving the blood patch. How many of you would agree? Panel, would you give a test dose of Xylocaine adrenaline? And if you want to inject, say if you are injecting 20 ml of blood into the subarachnoid space, patient will get meningism. Nobody gives the test dose? Apparently in that report, they had given chlorprocaine. The other point that might interest the postgraduate is that if you ever give a test dose and if there is a hematoma, lidocaine actually reduces the strength of the clot. There is some evidence to that. So, I don't know, I thought it was sensible, don't you think? Injecting 20 ml of blood into the subarachnoid space is not a good idea. They get a lot of meningism straight away. They get kind of spasmodic pain. That was what I read about it. Do you think it makes sense, Vincent?
We are asked to do epidural blood patch for chronic intracranial hypotension. When that happens, definitely I want to rule out the needle is not in the subarachnoid space, because you may not get CSF. So in that situation, we would do it under image, fluoroscopy, to check.
Sure.
But the routine one, I must
Are
say,
you
I have
worried
not been-
about injecting blood in the subarachnoid space?
Yes, I do.
Then why not test? If you are the same anesthesiologist who put a hole in the dura, might be successful in injecting blood also. No, it's I want to...
I think the likelihood that you don't get CSF after a 16, 17 gauge needle is small, but I mean it's possible.
Yes.
But in a situation of intracranial hypotension chronically,
Sure.
that will be different.
Swarup?
This conference, but I thought since it's a PDPH, is a talk of my interest also, because of late, even in my hospital, being a teaching hospital, we do come across a lot of people who get a PDPH, maybe because it's been done by students. But as for since you are talking of protocols and all those things, I believe as and when the patient gets the PDPH or whenever you see the earliest symptom, the first thing what we also do follow, we have made a protocol. In fact, I'm conducting a big study on that now, I think along with my colleagues, whereby initially, of course, the standard protocol of giving hydration, head low and all those things, maybe analgesics. Best thing is, of course, if it is aspirated and caffeine is available, that's always welcome. But if at all after 48 hours, we find that PDPH is not resolving or maybe worsening on the VAS scale 7, 8, 9, then we may think of doing a blood patch, but in that condition again, ideally we are supposed to have an MRI so as to know where exactly is the puncture of the dura. That's one thing. And secondly, you have to basically sterilize the patient's blood.
Very, very relevant. I think he was not heard, I suppose. What he was saying is, before you do the blood patch, you must give a dose of antibiotics so that the blood is sterilized. Very, very sensible points, sir. Well taken. I think it's, I'm sure, are there any points?
Heal or give all medications.
Sure.
And she can't feed the baby. I
Correct.
mean, she's in total distress, baby is crying. I think, indication will be, immediate.
Certainly. I think shall we all come to the consensus that one, it should be, as he said, if it's a worsening PDPH, maybe even second day is not a bad idea. Second, like the panel mentioned, the severity of and also social issues. Yes, definitely a mother has to sit up and feed her baby. So I think we should stop the discussion on that about...
Hello. Provided there are no extreme symptoms like Dr. Bala Venkat is saying, what am I justified in doing the blood patch as a last resort, say even after 5 days?
Why should it be last resort? Why not a little earlier, progressively?
Because aren't there problems with epidural blood patch also?
Sure, but I think we do explain about the possibility of infection, and we are talking about pain relief. We have, I think, I feel we are all, what does the panel say? Vincent, what's your opinion?
Because
should we be aggressive?
Because even today in my experience, there is a drug called tablet Espazin Plus, which is a combination of escazine and chlordiazopoxide, and which works very well. It's 1 BD dose for 3 to 4 days. And
What is the drug?
that is trifluparazine and chlordiazepoxide.
Oh, okay.
And that is, the tablet is known as Espazin Plus. Very simple thing to do. And so last thing I want to know is what are the other problems apart from compression symptoms as a possible problem of epidural blood patch?
Of course, the infection.
Infection. There's only two things.
We do have, in fact, we do talk to the patient about possibility of infection, but my personal opinion is we should not be going with a red flag talking to the patient that I am likely to cause infection, but I'll give a patch. But if you say we'll give a patch, you'll get relief, but there is a small chance of infection. So because the patient should not be unnecessarily put off.
So I just wanted to add just a little bit onto that. We also use Espazine quite commonly in our hospital. We found it very useful, especially when mothers are quite distressed and they get psychological symptoms because of the pain. Then this trifluparazine helps to calm them down as well as decrease the pain to an extent. One more drug that we found very useful is theophylline. So we use Derifilin SR retard,
Okay.
that helps a lot.
Okay.
So using these conservative measures and giving an abdominal binder,
Sure.
it helps to postpone the necessity, and actually I can't recollect doing a blood patch for the last 10 years.
Oh. No, we have done a few, I
I think Dr. Vincent is a bit surprised by this mode of treatment. Dr. Vincent, can you just clarify this?
I have not heard of this agent. It would be nice to be published somewhere so that other people can try and prove that it's so effective.
Okay. I think,
Dr. Bulli, just
yes, sir, yeah?
I just like my perception of this epidural blood patch is that one thing is that why the epidural blood patch is not given in the early is because the main mechanism by which it acts is either by increasing the tamponade effect and the blood clotting there and sealing that area. In the early phase, when the dural puncture occurs, a lot of CSF is in the epidural space, and if you give the blood, this blood doesn't clot. The only beneficial effect is because of the tamponade effect. If you give it after 2 or 3 days, by that time the seepage has decreased and coagulability of the blood is retained.
No, actually I don't agree with you.
No, this is just perception, I don't know.
Correct.
I may be wrong.
No, your second point will take it. No, we still have 45 minutes, Sandeep. 1 minute. See, I talked to our, no, don't take the mic, give it to him. I talked to our neurosurgeon. I asked him, does the blood clot in CSF? They say yes, it does.
Okay, so that is
yeah.
okay, the second issue is that during this epidural blood patch, the second concern should be that we should not cause the high pressure CSF headache. So how to monitor that? I was under the impression that perhaps giving the epidural blood patch in the sitting position, though it will be uncomfortable for the patient, but the moment you give it, you can titrate it to the rigidity of the neck, because it acts spontaneously. The moment you give 5 cc, ask the patient to move the neck. Is the rigidity relieved? The moment his rigidity is relieved, don't give more than that blood. I'm not very sure because it's long time since I gave a blood.
That is the prescribed procedure for, you don't predetermine the volume. You go on injecting. When the patient has relief from headache, we stop at that. And that is one point against giving a test dose. If you give a test dose, patient may get relief and you don't know how much blood to inject. Okay? Anyway, any other points about
Actually, why some patients develop PDPH, there is a theory of spontaneous intracranial hypotension. There are recesses of the dura and there is a spontaneous leak is known in some individuals. These individuals, if they are given the lumbar puncture, they are likely to develop this. And it can go without remittance for many, many years also. Correct. There are reports. So epidural blood patch is the treatment for relieving that. And in addition to all other drugs, even pregabalin can be, gabapentin can be used for this pain relief.
In fact, when I was making a study about this, we realized that the PDPH has been reported 3 weeks after the lumbar puncture. So, yes, sir.
And the last point is that if you see the neurosurgeons operating intracranial hemorrhage, the blood goes into the CSF. If you see any neurosurgeon operating upon the spinal cord, a lot of blood remains in the CSF. So this CSF, this blood in the CSF gradually takes its course, gradually gets diluted.
Sure. Sir, may I request you to include this effect, the blood and CSF, the interaction. Is there clotting? What is the volume? Can you include it as a part of your study? And also, no? It's already commenced. Okay, somebody can take it up. In vitro can be done. When you do a lumbar puncture, you could collect. Okay, that's the food for thought.
Murli, can I add something?
Yes, madam.
I just want to give a warning. Not every headache is post-dural puncture headache. Many times in my hospital, the neurologist will stick a needle as thick as his finger into the subarachnoid space to collect some CSF, and they will be referred to us for a blood patch. On an occasion, I went and saw this patient, but the detailed examination revealed it just didn't fit in. It didn't sound right. Sent her for MRI. She had multiple petechial hemorrhages in the cerebellum, and finally it was diagnosed as vasculitis. Sure. Don't stick a needle for a blood patch until you are absolutely confident that it is post-dural puncture headache.
Yes, but fortunately for us, the PDPH symptoms are fairly well standardized, and you can actually see the headache when you enter the patient's room. But I think we will take that point, it's a relevant point. And I would also advise at this point, please do not take the back preparation lightly. Don't leave chlorhexidine or betadine on the skin. In fact, we had a discussion about that. After that, all my spinals and epidurals, I cleaned the back with povidone iodine or chlorhexidine, then wipe it with saline and let it dry. Then only I take my local anesthetic solution, so that there is no question of any contamination, because that also can cause meningism, which is quite troublesome. Okay, if there are no more points about...
I just want to ask one question now. This is, I don't know, how many of you people over here, including the panelists, have any experience with thoracic or cervical dural punctures?
I have experience with that.
How did you deal with that?
No, blood patch you mean?
Yeah, blood
No,
patch.
all our thoracic dural taps did not get headache. In fact, we reported, we also postulated that it may be because the CSF pressure there is low, but as Vincent said, most of the patients are lying down, so the pressure may not be much different. But I guess it's because we operate and give a open heart surgery scar which is much more painful, so maybe they don't realize the headache. Other small
blessing in disguise, I guess.
Really, I wanted to add in this.
Yeah.
Last 3 months, we had 3 patients of spontaneous intracranial hypotension. So after the MRI was done, it was found to be having a cervical leak and a thoracic leak. But for both these, first the thoracic and the cervical, we did a blood patch.
Okay.
And that got relieved very fast.
Okay.
I think
and what was the volume that you injected?
In the thoracic region, we injected 10 cc and 8 cc in the cervical region.
At the same sitting?
No, different area. One after the other, or a 2 days gap.
2 days gap.
Yeah.
Okay.
Yes. Can we have an ambulatory mic?
May the leak be in the cervical region or thoracic region? Actually, there are papers showing that the lumbar injection helps reversal, because it is actually the pressure reversal which helps the PDPH. So you can inject in the lumbar space, which is much easier. You need not, there is one mechanism of blocking the leak, but the pressure reversal theory says that even if there is a leak in the cervical region, you give the injection in lumbar region and the pain is relieved.
But don't you think the leak might increase in the cervical space?
But there are reports that it is relieved with that
No,
completely.
because you are essentially compressing the dural cavity. Okay. We have a question here from Dr. Poria from Rajkot. If spinal fails at first attempt, can it be repeated? How many times? How many times some can be repeated, and in how much dose? What are the chances of PDPH? Of course, we have now, all of us know the answer for the last question. PDPH, I'm sure you be ready with a blood patch. But anybody, audience, I mean the panelists, anybody has experience repeating in the audience?
No, I think...
One with the highest experience will get the Sandeep Diwan award. No? Yes? Bala?
No, I think there is clear evidence that there are 2 options when you have a failed spinal. And we discussed in the morning on what do you define as failed spinal. One is absolutely no block. And next thing, it was inadequate in terms of the extent, the quality of the block, which means that partially the drug has gone in and partially it isn't. So these two things are very important, and now the choices are either go for a repeat spinal or you go for a general anesthesia. Both can be done, and if you decide to go for a repeat spinal, the next question is what dose that you need to use. And this is actually a very tough question to answer, but the current thinking on this is, it depends on, you have to wait adequately that 15 minutes, make sure that your spinal has totally failed. Occasionally you come across that you shouldn't be in a great hurry that the next minute you put the spinal, it works. Sometimes it takes a longer duration. We saw that once the drug is injected into the CSF, it undergoes 3 phases. And you need to probably, before you decide to give a repeat spinal, you need to probably wait for that 15 minutes to see for sure that the spinal effect has not come, and then you can repeat the dose. If there is no block as it is defined, then I think you can go for the predetermined dose which you did the previous time. If it is patchy, then it's up to your discretion, but you should probably go for 50 to 75% of the dose that you used before, mainly because you're concerned about a higher level of spinal anesthesia. And my option would be in this situation is, number one, an experienced anesthesiologist should take over this procedure, and whenever possible, it's better to go for a combined spinal epidural in this with a lower dose spinal.
Sure. Satish, you have any comment?
One more thing. Yesterday in the paper presentation, one paper was presented from Ganga Hospital only about second spinal. In that one, the author who was there, he said that they aspirate in 4 quadrants. So you make the needle 90 degree, aspirate little bit 0.1, 90 degree 0.1, 360 degrees. Then they make sure that the needle is inside. In all the 4 quadrants the CSF is coming, and then the spinal is given. They found that in the repeat spinal, the incidence of second failed spinal was almost zero.
Well, that's
a word of warning,
wonder.
Murli, Dr. Vaid, if you don't mind, can I?
Yes, sir. Yes, sir.
Yes. I think when you give a second spinal, no matter what dose you have calculated, one should be totally prepared for a high and total spinal. You don't know what is the level of it might go up. So whatever calculate, maybe half, 3/4, you must be prepared for a high spinal. All the preparation will be ready, and then you give what you want to give.
Sure. Anybody wants to comment about rotation of the needle? Vincent? You had some point to make.
Not the rotation, but I like to poll the audience. How often do you reduce the dose when you do a second spinal when the first one failed?
Those who are giving second dose or the lower dose, can you raise your hands? Oh yeah, it's a majority.
And how many would use the same dose?
Same dose. In case the spinal has failed completely, same dose.
Fail.
Completely, if it has failed, same dose.
Right. But I think another point about failed spinal is I grew up in the era of Cauda equina syndrome. When a failed spinal may not be a failed spinal, it's just maldistribution. And I always check the bum because the legs are moving, but the bum is numb because it's usually hyperbaric solution. So I would definitely check the bum to see whether the local anesthetic is there, and I may then change the porosity of the drug. I would change the isobaric solution, perhaps, maybe change the position of the patient, and also may do it at a different level so that the drug is not going to repeat and go back in the sacral area, because that's the cause of Cauda equina syndrome.
Sure.
Here in this case, our resident who was doing a case of THR, total hip replacement, he gave a spinal, and that spinal did not work for approximately 15 to 20 minutes. Then he decided to repeat the spinal. The moment he put the needle, he had not injected the drug. The moment he put the needle second time, the patient collapsed. And when it was checked, it was a quite high spinal with the fixed dilated pupil.
Oh.
We couldn't explain what was the reason, and there were so many hypotheses. Perhaps the drug was in the subdural extra-arachnoid space, or where it was there. But just by putting the needle, it went very high, and the patient crashed. And this was reported also later on, but we don't know. So I am just saying that one should be cautious when they are giving the repeat spinal.
Sure. No, I think that's exactly the point Dr. Joshi was also making. So we'll be careful when we do the thing. There is a second question from the same doctor from Rajkot. He asks about epidural needle insertion. If you make a dural tap, what will you do? Will you give a spinal through that? And what will do about that? How many of you would want to, if you accidentally enter the subarachnoid space during an epidural, planned epidural, would convert that to spinal? You would, Vincent? Yes, Satish?
We will put the catheter intrathecally, about 2 centimeters intrathecal in the intrathecal space. Yeah, confirm on aspiration the fluid of CSF, and then inject the spinal dose intrathecally.
You would agree with that, Vincent? Okay. Anybody else in the audience does differently? What is that? Question is, if you accidentally enter the subarachnoid space during an epidural, what would you do? But I guess yes, Bala?
No, but one of the most important thing is like this catheter either has to be removed when the procedure is over before sending to the ward, and nobody should construe this as a epidural catheter. So then we might end in a catastrophe. So that's very important.
Murli, I think Murli, I think I'm a different opinion. If I'm putting an epidural, I think you have to take into the consideration about what patient population you're putting it. What is basically it's orthopedic cases or obstetric cases, what type of, whether it's epidural anesthesia, what. So in context of the situation, but most of the situation I'll pull out the whole thing because we don't practice the intraspinal catheters. And just
of course, is there Vincent? Can you throw some light on what's the practice of intraspinal catheters in your country?
I have no experience with intrathecal catheter other than cancer patients. I do that for cancer patients, but not for post-op.
Sure, I think Swarup Bala did address your issue. He said the patient should not go back to the ward with the same catheter. One is for the fear of catheter causing the Cauda equina kind of problems, and second is inadvertent injections through that. Sure, I think we have a consensus here. So I'm sure
Sorry, Murli. Yeah, this is, with the intrathecal catheter, we had a problem of accidental dural puncture, and then that was managed by the concerned anesthetist, and it is the anesthetist's responsibility to look after that, because that patient was with so many comorbidities which had to be maintained under spinal anesthetic for the procedure and post-op analgesia, and that anesthetist concerned maintained that, looked after that. Nobody else was allowed to use or inject anything into the catheter, and then we removed it a day after.
I am extremely worried. I think the best way of preventing an entry is to plaster the door, seal it off. If you keep a door, somebody will open.
Yes,
so I would not want to keep a catheter, I would remove it.
Absolutely.
And if you want post-op analgesia, I'll put in 200 mics of morphine in the subarachnoid space. But I am worried. Okay, its panel is also worried.
Hello. What about the anesthesia part? Won't you like to, if it's a prolonged procedure, won't you like to remove the epidural needle and attempt it at a second space? Most of us have done this several times.
Yes.
Sure.
I'm sure you all.
So that's
Then instead of giving spinal, once the spinal is in, it will be difficult to give epidural again in the second space, isn't it?
I think it's more of a blanket questions we are asking. We have to take into consideration what situation
That's
we are doing. Whether it's orthopedic, obstetrics, labor anesthesia, whether it's coming for category 1 cesarean section, category 2 what. So what situation you are. So depending on that, I think we have to...
That's what I wanted to say.
Yeah, sure. No, regarding labor anesthesia, I did mention the guideline. They also suggest two tabs. One is the needle tab, other one is the catheter tab. Needle apparently was in the epidural space, but when you put the catheter, CSF returns. So it's been very nicely discussed. It's a very strong suggest about that reading. So the second issue that we are going to discuss is the suspected pneumothorax after a supraclavicular block. Okay, I want to ask Satish, do you always use ultrasound to form supraclavicular block?
Nowadays, yes. Previously, obviously, when I trained, we didn't have the ultrasound, and we used to go by the landmark technique, and we were always trained, to go and hit the first strip, withdraw a centimeter, aspirate, and inject the whole dose, and it almost like works like a spinal of the upper limb. But now, since we have the ultrasound, yes, we do with the ultrasound guided.
But do you think you are now better off? More knowledgeable?
Definitely, there is no question about it. There is no question about it.
I guess
you can actually, I mean, the advantages of doing it ultrasound guided, I don't think you can argue with that. You can actually see the way the drug is being deposited around the nerves, and it is. You can actually see if it is intravascular.
Sure.
You can put the drug where you want to, and the success rate is near 100% now. I would say it can never be 100%, but it's much higher than what you do by the landmark technique or even with the nerve stimulation technique. The success rate is definitely higher.
Anyone on the panel has had an experience of pneumothorax after a supraclavicular block? I guess all of them would raise hands.
No, once I was very bold enough when the continuous catheters were not there. I tried to give, that was a blind technique because PNS was also not available, ultrasound was not there, that's long time ago. I used epidural set for giving supraclavicular block, and that punctured. So that patient, that is the only patient which I know who had a pneumothorax. I had to wait for some time, we had to put a needle to remove the air. The patient went off well, but because of my ignorance of my this one, there was pleural pneumothorax which was there.
Sure. No, I really appreciate you for bringing about a personal failure into an audience like this. I think if more of us do that, then there will be less people committing the same error.
I had 4 cases of pneumothorax supraclavicular block in a week, and I've given up that technique.
This is what exactly I wanted to say. In fact,
it comes in crops, seasonal?
No, not seasonal. In fact, you don't teach all your juniors, do not teach because we have multiple approaches that are available now, so don't teach the techniques which are known to produce this complication.
Sure.
So that's number one way to prevent. And number two is not all the time, because majority of the time when it is done, the prick that you produced in the pleura doesn't always result in a big pneumothorax. But there are many instances that the drug sometimes that you didn't know that you have done it. So you inject the drug, many times it is manifested as a pleurisy. Patient starts complaining of discomfort when you take a deep inspiration. And probably we think it is because little bit of the drug entering in the intrapleural space this is one thing, and most of the times when you do a chest X-ray, you don't see anything there, but the patient keeps complaining it for a few hours, then it disappears.
Sure.
So there's another thing which I want to share, but best way to avoid pneumothorax is don't teach the technique.
Sure.
Which
Vincent, you had a point to make?
I would disagree because, in fact, one of the techniques that we teach residents is supraclavicular, but we emphasize, we all worry about pneumothorax. So I always say it's easy to see the nerves, but you must see the needle tip. If you don't see the needle tip, don't just keep going in with the needle. And also use different hydrodissection, scanning. So the emphasis is we do teach it. The onset is very fast, but when we teach it, we emphasize those points again and again. Don't do the in-plane approach. If you don't see the needle tip, don't advance. You must see the needle tip before you go further. So we teach our residents, these are junior residents who is in their second year of residency, and we do it in inpatient and outpatient. Obviously, they are supervised.
Sure.
We'll be keeping an eye on the progress, but we do teach it.
No, the only difference between probably your infrastructure and the infrastructure here is not all the teaching hospital has got an ultrasound machine. So still many of them teach with peripheral nerve stimulator. So where there you do not have a judgment to see where the pleura is. So when I said I meant more on the peripheral nerve stimulator, which is there in most of the educational institutions, and majority of them still don't have ultrasound machine.
Sure, but I guess the whole audience agrees. Yes, 1 minute.
Only one thing is I had a similar episode on supraclavicular block I had given. Went off very well, patient was comfortable, went home in the evening very nicely. But came the third day back with a tension pneumothorax.
Sure.
So please keep in mind this
In fact,
could also happen.
Sir, that is the next my question is, how do you diagnose, Swarup?
If you see this patient, most of these patients are asymptomatic. As sir said, this patient can actually be symptomatic anytime. So most of the time, these patients are asymptomatic. But when you are doing the blocks and you feel that patient is actually, while injecting or you're passing the needle, if the patient develops the pain, as well as the cough, which is suggestive of the pleuritic chest pain, that is a classical suggestion that you have puncture the pleura, which is likely that patient is going to develop some degree of pneumothorax. There is a literature which says that patient will have some degree of severe pain, cough, dyspnea, and there are some reports of actually hemoptysis. And if you, apart from this clinical examination, if you suspect and proceed and do a clinical examination, sometimes you may feel that patient is developing pneumothorax, resonance on the particular affected side. And if it's more progressive, more large degree of pneumothorax, then you can do ECG changes. Sometimes you can even see the QRS voltage is actually going down.
What do you think is the role of ultrasound?
See, I recently attended the 6 months back, we started with doing ultrasound lungs, and then we started doing this ultrasound lungs for all the block, supraclavicular block cases. And I think it's a very nice extension of all the ultrasound. And we started doing the ultrasound lungs for all the patients. It's very sensitive, and probably a negative predictive value is almost 100%.
Sure. I'm sure when we are actually injecting or visualizing the nerve roots, you can, under the subclavian, you can see the pleura moving in and out. Sometimes you can see the pleura immediately receding, suggesting there's a massive pneumothorax. It may not happen all the time, but I do take this point of Swarup that you could do a chest ultrasound post-operatively on the side on which you have done the block, and it's very easy to see the pleural end shining wherever you put it. And I think we should not wait for the hypoxia to manifest as one of the manifestations of pneumothorax.
If you see the, if you see the this X-ray chest diagnosis, most of the time, 80% of the times, X-ray is not diagnosed with pneumothorax.
Sure.
And most of these patients are lying down in supine positions, and this all air collecting the sulcus, so which is normally not diagnosed. So it's a late presentation.
Correct. We may not know the actual incident. Yes, Arya?
Using the nitrous oxide, I had the incidences. When the pleural puncture was done and GA was given, it manifests under the positive pressure ventilation in terms of the bronchospasm and tension pneumothorax. But
Sure.
if the patient is kept this spontaneous, then it may take long time to develop, or many times it may resolve itself. And
Sure.
as it is said that this ultrasound is very good for diagnosis.
Sure. And my other suggestion to the youngsters is, when you are making a block, if you aspirated air, even if nobody sees that, please report to your senior. Many a times you say, oh, the needle was loose and again tighten in, you think that nobody has noticed it, but don't work on that. If you aspirated air in the neck, it's mostly that you have done it from the lung. It's not from the atmosphere. Okay. Bala, is the anesthesiologist's experience or inexperience the risk factor in producing this?
Yeah, surely if it's, I think that answer was told by Dr. Vincent, and in a supervised block with an ultrasound, I think it makes it, make sure that you're never near the pleura. But if what's done in our country, like even many centers still use paresthesia technique and then they use peripheral nerve stimulator, and I'm sure it does make a difference between the experience and producing one.
Sure.
May I make a small comment? Here we are talking about ultrasound and peripheral nerve stimulator. There are many centers even just now in India where even PNS is not available. And I have been working in a teaching institute for last 30 years. And even though a lot of hue and cry is made about pneumothorax is not so common after a blind supraclavicular approach also. Only thing is one has to be aware of the complication. We are always telling the orthopedic residents who are discharging the patients and our residents to do the 4-quadrant auscultation before they are sending the patients home. I think it is, I mean, people may not agree with me, but it is a very good technique. Even blind supraclavicular is a very good technique, and it should not go out of medical curriculum. We must teach them the supraclavicular approach.
Dr. Satish, I just wanted to ask you, you mentioned about the anatomical based supraclavicular blocks. Dr. Bala can contribute. Most of the learners or beginners, they hit the first strip and just deposit the drug, mentioning that it can block the supraclavicular nerves. Your take on it?
That's the blind technique what you're talking about, right? Yeah, I mean, that's what we were trained for. I really don't know.
But honestly, I really wouldn't do that. Not only because actually Kelka madam is my teacher, but then here I beg to differ, because those who wanted to really learn this, I feel subclavian perivascular is much superior technique, and the nerves are much more closer to each other at that place. When you see on the first rib it's lying scattered, whereas when you see it in the subclavian perivascular it's absolutely compact, and you can see the block, get the onset of the block even with a stimulator. It's just very fast. We'll never achieve this with the classical supraclavicular approach.
Okay, there is a question from the audience that what are the discharge criteria after spinal anesthesia? Obviously, as a daycare procedure, I guess it's fairly well established. The spinal should wear off, patient should be able to move the limbs, and there should be no residual neuromuscular weakness, and the patient should have passed urine. Anything else that you need to add on that discharge criteria?
Yeah, because I think this question is pertinent, because many of the centers in this country, if they said that the patient had a spinal anesthesia, they want an admission for a day.
Okay.
So that they still believe in it, but I think what you have answered most of it. I think the patient can go home.
Sure.
And yeah.
Okay, there is another interesting question, the legal angle. When there is a residual neurological deficit after a block, and the orthopedic surgeon claims that the anesthesiologist who has to share the responsibility, and this man doesn't want to share the responsibility. What is your view? Is he liable?
No, actually, I think for sure they're liable, because both were involved in doing the case, and we do not know whether the neurological deficit was surgical or whether it is related to anesthesia. We do not know. It's based upon what kind of surgery. For example, if it's something to do with a total hip replacement, and then you have a sciatic palsy, and the anesthetist probably in this particular, it depends on the situation rather. Similarly, if you're doing with the humerus surgery, the radial nerve is pretty close by. So it depends upon what type of neurological deficit, and most of the times now they subject the patient immediately after that to the nerve conduction studies. Correct. Which clearly indicates.
Absolutely.
But whatever said and done, any fallout happening inside the theatre should be equally shared by both. Only then the relationship continues, otherwise you part ways.
Okay, that's another game changer telling us.
No, I think it's my question actually. I just want to ask, depending on the level of the blocks, can you differentiate whether it is orthopedician's handling or it is because of the inadvertent neurological injury? Because it happened, the patient had a radial residual block, and then I had given a supraclavicular. Everything has improved. for few days we observed and it improved. But in case, if it doesn't happen legally, how can we settle it?
So this is regarding supraclavicular brachial plexus block, or any, I think it's probably easier if it is interscalene, when there are separate nerve roots that you're targeting, as opposed to the surgical, this injury caused by surgery due to peripheral nerves such as axillary nerve, musculocutaneous nerve, and suprascapular nerve. Because what I've been talking to the neurologists about this, what you can differentiate is using the EMG to look at non-overlapping muscles. Particularly for C5, C6, C7, you're looking at the paraspinal muscles. So EMG can tell you that is likely the nerve root, as opposed to the peripheral nerves injured during surgery.
Murali, can I just...
One of the other things which is very, very important is the tourniquet, which is being used very widely, and in many centers even now, the tourniquet is used and they still use the automatic pump to pump it and then put a clamp. Still, so these are the places where it needs to be really, really careful, and anesthesiologist has taken the responsibility of the inflation and the deflation time to be noted, because many times this has resulted in severe neuropraxia to the patient.
It had happened to me many years ago. A flutist who was high on drugs put his hand through a glass of wine and then had a puncture. He was taken up for tendon repair, and I had given a brachial block, and surgeon had put a tourniquet. In spite of warning him about the expiry of the tourniquet time, he said nothing will happen, and the patient required a general anesthetic. Then procedure continued. After the removal of the tourniquet, 2 days later, patient had no control over elbow. The surgeon told the patient that the anesthetic block which was given probably caused this. And I had a huge, if you go on talking like this, I'm going to document that you exceeded the tourniquet time. Let us see who will win. Then it settled, and one day when I was going out of the hospital, the same flutist was going on a bike, and he said, "Hey doc," and he did like this and went. So obviously he improved.
Murali, just in extension of the question this gentleman asked, this doctor asked on the floor, we have a controversial issue with patients coming for the reverse shoulder. And guys who do a lot of shoulder surgeries will understand or would have seen the way the surgeons manipulate and externally rotate and literally take the hands off to get the ball and socket in a different position when they do the reverse shoulder. The controversy here is whether to do interscalene block or not. And now what has happened is, in our institute, we don't do reverse block for the reverse shoulder, unfortunately, and they give the local anesthetic because they take the responsibility for the pain control and then go on PCA. The reason is because when they do the reverse shoulder, they stretch the brachial plexus, and if anything happens surgically or surgically caused, they won't blame it on us, so we don't want to take the responsibility. So I just wanted to know, what is the practice here for a reverse shoulder, because arthroscopy is different, total shoulder is different, and reverse shoulder is different, because surgical approach is different, and the manipulation and extent of your brachial plexus torturing and thing is different. Yes.
I agree with Murtazasalam completely. I personally also don't like to give a block if there is a scope for a neurological injury during surgery. So I don't give blocks for carpal tunnel at all. I always give a general anesthesia because of this problem what this doctor has mentioned. I don't want to share the legal responsibility. I don't mind my responsibility, but when a patient can be anesthetized by general anesthesia for carpal tunnel, why not? Any comments, Vincent?
Maybe I will add something to the reverse shoulder too. At some point, some of my surgeons who were learning to do reverse shoulders, they came and said, no blocks for my patients. So we backed off because we are after all interested in the welfare of the patient. Patient is the most important person in the whole wide world. So after some time, they got a little confident. So what we agreed, I will put a stimulating interscalene catheter, but I will not bolus it until the surgery is over and he can do his neurological exam. Once the patient is comfortable and all the documentation has done, I bolus my catheter and continue with analgesia. So I got the best of the both worlds, and the surgeon likes us that way.
But what if the neurological injury appeared later? It might not appear immediately after surgery.
Well, in these cases, it's almost pretty soon after surgery that they get. If the reverse shoulder stretching occurs, there is an immediate neurological dysfunction.
No, but I liked what you said in the morning, that you would tell the patient that a surgical procedure also could cause a neurological injury, and that's it.
Yeah.
But if there is a chance where you don't have to lay your neck on the block, you don't have to stick it out. That's what I would say.
I agree with you on that. If you don't have to do a block, don't do the block. There are some patients who are very sensitive to narcotics and they go squirrely-whirly on narcotics. I can't put them on a PCA. I may use a local infiltration, and that is quite often that's my second choice instead of the narcotics. The other thing that I wanted to comment about going out of that is, anytime you have a neurological injury or dysfunction post-operatively, Terry Horlocker all the time talked about it. Don't just settle with doing the EMG only on the affected side. Do it on the opposite side. How did Brian Sykes discovered that this patient had multiple sclerosis following prolonged deficiency following interscaling? They did the bilateral nerve conduction study. In the United States, it's a must. And they do a baseline soon after injury, and they repeat it 3 months later or 6 weeks later. My neurologist won't oblige me on that. They will oblige me with bilateral, but they won't oblige me with doing an instantaneous or immediate post-operative EMG followed by 6 weeks later to look at the things. So there are some contradicting paradigms in this. Maybe Vincent will know a little bit better than...
Sure, I think I agree with bilateral nerve conduction studies. And shall we go back to the point of sharing responsibilities?
Well, we do the same thing if a block is indicated, if the surgeon is concerned about the potential neural injury intra-op, we'll put a catheter in, and after the examination, post-op, then we'll dose the catheter. I think now we learned the lesson is we had seen neural injury after surgery. So now we are more proactive. We talk to the surgeon ahead of time. We all agree for this type of procedures, what we're going to do. And if, as Sue was saying, if the surgeon is just learning how to do the procedure, he or she is not comfortable, obviously we won't do it.
Sure.
Because otherwise, it's
I
asking
think
for trouble. So we have a protocol. We all agree.
Correct.
If everything equal, we will do it, but we have that agreement ahead of time.
Sure. Any comments from the audience about that? Yes, sir.
I confirm the remark of Dr. Ganapathy. We are very scared with reverse arthroplasty of the shoulder because young surgeons tracked a lot of on the shoulder to operate, and the duration of surgery sometimes overlasts more than 4 hours or 5 hours. But the question is, they ask me because I got one, and unfortunately the patient had got a single shot block. It worked very well, and it long lasts curiously more than, and there is a delay for the diagnosis. And I'm criticized because there is a delay of a diagnosis. Is it because my block, or because of delayed nerve palsy? But the question of the surgeon is possible because the injury is caused by the surgical traction and by the action, the joining action of local anesthetic, like double injury. Can you comment about this? Is there a possibility of a double injury? Injury by the surgeon, by tracking, and injury by maybe action local anesthetic, or a little puncture over the plexus?
Yeah?
There is a possibility of that, but the chances will be rare, because we have to go for one. Yeah, I mean, the chances of getting a double injury are rare than getting one injury.
Okay, we'll come to the last question, very simple question. Diluting solution for local anesthetic during injection: A, water for injection; B, saline; C, 5% dextrose. I guess it should be saline because both are acidic. We should not have any. Oh, is it because of the pH variation that the gentleman has asked a question? Any comments? What would you use? Does it really matter? Dilution for local anesthetic injections.
We all, I think so, panel uses normal saline, everybody.
Normal saline. Because the question is asked because the normal saline is acidic. and the local anesthetics are alkaline. So will there be a pH change?
I may add some knowledge on that. We did a study. The reason behind the study was if you had a normal saline, you deliver a certain amount of sodium along with the local anesthetic. And that may overwhelm the sodium channel before you had a chance to get the local anesthetic into the thing. It has to be in an active state for the molecule to go and attach from inside. So we thought we will dilute the local anesthetic with 5% dextrose and compare it to the blocks onset and offset when we mix it with normal saline. Lo and behold, when we diluted it in the 5% dextrose, it kicked in quicker. There was no difference in the duration of action. That was published by Dr. Dheer again. She's the one who did the study. The thing that happened with that study was we were trying desperately to get some crystals of ropivacaine so that we can do the entire dissolution in 5% dextrose. AstraZeneca wouldn't part with it. So we had to dilute the regular ropivacaine, which is ropivacaine hydrochloride, diluted in dextrose or saline. That means we would have the concentration of sodium in it. It definitely makes a difference. It makes it quicken marginally faster and lasts the same duration.
Did you publish it?
Yes, it is published.
Okay. I think it's one of the useful thesis topic for our postgraduates.
I was there in Madam's talk also about 5% dextrose. In your talk also you had mentioned about this.
Sure, I think it was a very useful question at the end of the day. We should change over to dextrose, and people do fear dextrose for the fear of producing infection. I think we should not be too worried. And
small question related to this. What is the role of the preservative in a preservative containing local anesthetic? Is it to prevent infection or is it to make the molecule stable?
It is for the shelf life.
Regarding infection or
no, shelf life. That is to increase the duration.
Stability.
Stability of the molecule. It has nothing to do with infection.
No. All right. I think we have come to the end of a wonderful conference, which was an academic treat, and I'm sure all of you enjoyed the panel as much as I did, and we'll give a big round of applause to the panelists.
I thank you all for this. I request everybody to stand up for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नाम जागे तव शुभ आशीष मागे गाये तव जय गाथा जन गण मंगलदायक जय भारत भाग्य विधाता जय हे जय हे जय हे जय 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 जय
No, I just wanted to thank Sandeep Diwan and Sandeep Mutta, the two Sandeeps who toiled for months together to make this a possibility, and a big round of applause to them. And the entire organizing team and the Pune City branch, which gave shoulder to shoulder, and all the staff of the hospital and the administration. And it was so nice to see the live workshop going until 8:30 in the night, but still all the anesthesiologists and the staff working. And to all our international faculty, Professor Vincent Chan, Dr. Su, Dr. Charles Wu, Dr. Swaroop and Dr. Mardan.